Welcome to the Innovation in Cancer Bite-Size Learning event. We are going to be spending some time this morning talking about innovations that we know about and some of the innovations that we would like to see in cancer programs moving forward. There'll be a couple of presentations, one from me, Sharon Robson, and one from my colleague Steve Lynn from the Academic Health Science Network. And then there will be some time to answer questions and comments that you can put into the Q&A box. So let's make a start. Can you move us on to the next slide, please? So, as I said, welcome everyone. This is a new format for us, so we're quite excited by delivering these short bite-sized sessions into the week for people. We're running this instead of the annual conference that we would normally have, but bearing in mind, people's availability at the moment with the pressures of COVID and winter, we thought it would be better to have some short bite-sized sessions updating people on projects that the Alliance are working on across cancer pathways and use this structure to deliver that information. These sessions are being recorded and will be available up on the website following the events. So, if you hear something that you think would be of interest to a colleague, please feel free to highlight the opportunity to them to look back on the events. So just in terms of letting you know who's kind of behind the camera, if you like, my name is Sharon Robson and I'm Programme Manager for Early Diagnosis with the Cancer Alliance. My colleague Steve Lynn from the Academic Health Science Network will be taking us through the second part of this session. And I'm being ably assisted by my colleague Sue Young, who's handling the presentations and the technical end of the session, and Michelle Wren, who's one of our service improvement staff, who will be managing the Q&A for us. So that's who's on the call. The plan for the call is what you can see up there. We will give you an update on the current innovation work within the Cancer Alliance. And what we're doing there is I'll take you through what we know about the innovations that are out there and where the Cancer Alliance is in terms of implementing those. And now I'll hand over to my colleague Steve from the AHSN to tell us a bit about how we link with the Academic Health Science Network and how we're going to work with them to tap into the unknown. So those are the innovations that we would hope are coming along and that we wish and we need to develop to help us address the aims for cancer, which are, just to focus back on people, the whole reason why we're doing this innovation work is that we have significant challenges in the long-term plan around earlier and faster diagnosis of cancer, and also improved treatments and improved outcomes for people with cancer. And we are hoping that innovation can help us with all of those, including, specific challenges that we know about in our systems, such as the lack of a trained workforce. Radiology comes to mind for that. So that's what we plan to do this morning. I'll take you through that first bit of the known. I'll talk about the things that the National Cancer Team are funding, the projects that we're using some innovation funding for locally, and I'll talk about a couple of schemes that are in the discovery phase for us. And then I'll hand over to Steve and he'll take us, so there'll be a chance for some questions at the end of my slot. And then we'll hand over to Steve and he'll take us through how we can all work together to develop some opportunities to look for innovations that can contribute to cancer pathways work. Next slide, please, Sue. So this is the slide on the initiatives that are currently being supported by the National Cancer Team. So the first one that I want to talk about is colon capsule endoscopy, and that's a project that has been developed over the last few months and is about to be rolled out and go live from January. So, you know, we're right on the cusp of implementation of that one. And then I'll say a little bit about Cytosponge, which is the second innovation project that the National Cancer Team are supporting. So in terms of the colon capsule endoscopy, this may be something that any clinicians on the call might already have had sight of or some understanding of. Essentially, it's a tiny camera, a pill cam, that is swallowed, and the patient wears a reading belt around them. And as the little camera progresses through the colon, you know, on that figure there, going from points 1 to 9, it takes images as it travels through the colon, and those images are transmitted to the belt, and the belt is the bit that comes back into the clinic to then be read in the same way as a colonoscopy would be read by the clinician. So it's a new technology. The use case or the particular scenario that this initiative is going to be used in is in patients who are on a waiting list and have a fit score of between 1 and 99. So these are the lower risk GI patients. So they're not the higher risk ones that we know, because of their fit score, need to go straight to full colonoscopy. They are the lower risk patients, and so this technology will help us prioritize the COVID backlog. So these are lower risk patients who might have been waiting for some significant time and can benefit from this technology. As I said, it's a nationally funded programme, and nationally NHS England have contracted with Medtronic for the supply of these, and we're just now in the process of sorting out the delivery to hospitals across our patch to implement this this technology from January. As well as the supply of the cameras and the belts. There's also training for the clinicians involved, and the first round of that training is happening in January. So that's colon capsule endoscopy, and we will have sites in every ICP delivering this new innovation. And we will, following the second round of the training, we'll have delivery at almost every hospital across the North East and North Cumbria. So that's great. I mean, I think longer term, there's quite a lot of evidence of the use of this particular innovation, particularly for patients who might find it more difficult to come into clinic. So, you know, it's been used successfully in you know, parts of Africa, where the patient can be administered the pill cam and you know, do that process at home, so much reducing travel into clinical centres. So I think longer term we could potentially look at the use of this innovation in some of our more rural areas to help with you know, patients who might be unwell and not want to travel into hospital. The second initiative that the National Cancer Team is looking at, and this is slightly more in development, is the Cytosponge. And again, you know, I am not a clinician, but my understanding of this particular technology, it is like, if you imagine a little sponge on the end of a string. The sponge is swallowed and then removed, and as it is pulled back out, it picks up some of the cells in the esophagus, which can then be examined to see if there are cell changes that might lead to cancer. So I know that for one of the use case or the scenarios that they're assessing this innovation for is for use in Barrett's esophagus. But all we've done at this stage is to look at who might be interested in being a pilot site for Cytosponge. We already know, again, that a couple of trusts have picked this up for themselves, but it's likely that it will be offered in the same way as Colon Capsule has been, in that an offer will come from the national team for potentially some of the kit and the training to be rolled out possibly in February or March. So those are the two initiatives that have been supported by the National Cancer Team, and our role as an alliance has been to bring together local clinicians to support the implementation of colon capsule endoscopy, and now moving towards thinking about Cytosponge. Next slide, please. So the next slide covers the local projects that as an alliance we are looking to support. We received through National Cancer Transformation Funding a pot of money for local innovation that would support our aims in recovering from COVID, as well as the cancer transformation objectives that are laid out in the long-term plan and our Cancer Alliance work plan. So there's three that we're looking at in year, and then a couple that I'll come on to after that that are kind of in development. So the ones that are further on in the discovery process are the automated breast ultrasound, a digital PTL, patient tracking patient timeline, and Pinpoint, which is a blood test. So I'll just outline those for you briefly, and then I'm happy to take any questions at the end about if you're interested in any of these technologies. So colleagues on the call, I'm sure, will be aware that for some time we have had concerns about the vulnerability of our breast diagnostic services across the northeast of North Cumbria. So the breast pathway is one that we would ideally like to improve, and the sticking point in that pathway is the diagnostic part of the pathway. We don't have enough trained and experienced radiology and imaging staff. So a solution to part of that issue, we think, could be the automated breast ultrasound, ABUS for short. That's a picture of it on the right hand side. So you'll see it's not that much bigger than the existing ultrasound equipment that would be in a clinic. It's slightly different from the handheld ultrasound that would normally be taken. Essentially what the machine does is the bit with the two handles on the top would fit over the breast, and the woman would be lying on her back while the image is taken. So there's no need for the patient to move around from different angles, because the image of the whole breast is taken in one scan. And so one of the advantages of this technology is that it can do the ultrasound more quickly than the traditional handheld ultrasound. And it also takes an image of the whole breast with the nipple located on there. So it's very easy and clear how any particular areas of concern could be identified and located, by somebody looking back at that image. The other thing, the other advantage that it has is that it can be used by a wider range of staff. So, that would help us in the, because we know that we need to increase the skill mix in that workforce. So you can have, obviously, the images, once they're captured, need to still be read by the imaging experts, but the actual capture of the image can be done by a wider range of staff. So in terms of what we see as the advantage, as I say, it's quicker. I think the company say that they could do both breasts in the time that it takes to do the current localized image, which would just be part of one breast, used by a wider range of staff, and the image is of the whole breast rather than just part of the breast. Now, obviously, that leads, has some unintended consequences, because if you take a bigger picture, you might find other things in the picture that you might not have found in a localized picture. So we need to carefully think about how this is used in terms of protocols, because there's always the potential of unintended consequences and incidental findings, that might never have come to anything, but once it's been found, it has to be investigated. But that is the technology that we are looking at potentially piloting in one of our trusts. So we're looking for potential partners in that technology. At the minute, that technology just looks at capturing the image. Longer term, I think there's the potential, as AI and machine learning develops, that once we get to a point that clinicians are confident with the ability of AI to contribute to joint reading of images, it would be very simple to add artificial intelligence onto this type of image capture machine to enable that to happen. So that's ABUS. And again, there'll be time at the end for any questions if people want to ask specific questions about these technologies. The second thing that we're looking at as an alliance is to develop, if you like, a digital program that will help us visualize the waiting lists and the capacity and demand of cancer patients in one ICP. So we are working with the company through our colleagues at the AHSN to look at how we can develop that shared understanding of demand across an ICP, given that more and more we're needing to rely on perhaps shared staff or shared patients to enable the smooth flow of work through the limited resources that we do have in our providers. So we're hopeful that digital PTL will be available towards the end of this financial year, with a view to starting small, getting it up and running in one ICP, and then seeing if it will contribute to our work as an alliance as a whole. The third local project that we've got an eye to is a project that's been developed in the West Yorkshire and Harrogate, or in conjunction with the West Yorkshire and Harrogate Cancer Alliance, which is the Pinpoint blood test. And there's been quite a lot of things in the news this week around the Grail blood test, which is a great innovation and should help with some hard to diagnose cancers. The advantage with Pinpoint is that it's a blood test that's done on standard samples, so the samples that a GP would normally do when they have a concern of cancer could have this extra blood test done on it. And once it is it's an algorithm developed by an astrophysicist, and it gives a risk score of cancer to a particular case, but it's calibrated by population. So it would help with the prioritization of waiting lists. So it's not a rule out or a rule in test for cancer, but it would alongside the clinical decision making, it would help a clinician decide whether a patient goes on a 2-week wait or a routine waiting list. So in the West Yorkshire and Harrogate Alliance, they are currently at the point of doing that local calibration, where essentially they look back at a block of samples and they apply this algorithm to those samples until they get to a point where they have successfully identified 100 cancers in each tumour site, so 100 breast, 100 GI, etc. And once they've got that, they know that they've calibrated their algorithm to the local population, you know, because we know things like smoking prevalence or deprivation all have an impact on people's risk for cancer. So, you know, the algorithm is calibrated to the local population before it's applied and offered to clinicians as part of the decision-making process for referral. So those are the 3 local projects that we are hoping to deliver on in this financial year. Next slide, please, Sue. And then finally, I'd just like to tell you about a couple of projects that we are in development with. So the Densitas Breast AI project and Blue Prism are 2 projects that we're in the process of finding out more about. And with Densitas, we're looking to develop a bid for funding to support a pilot with Humber Coast and Vale Alliance. I mean, I think it's fair to say that a lot of the innovation work has really accelerated since COVID, and it's both created opportunities and shown us that services can change quickly, and sometimes that it's worth you know, testing in the real world some of these new ideas. So Densitas Breast AI is a program that runs real-time quality assurance of breast imaging. So currently, all breast imaging needs to be quality assured, and clinicians have to audit their work. I think it's on a monthly basis. So they have to pull, you know, months worth of cases, take a sample of those, and if you like, re-look at those to make sure that the decision that they made at the time is the correct one. What this program does is it uses artificial intelligence to do real-time quality assurance of the imaging that's being done, such that you know, the clinician gets some immediate feedback as to how consistent the reading has been, and you know, the ability to do that in real time reduces the need for staff to go back and reread things, because they need to remember what the case was and then reread the screen, whereas if they do it at the same time, it's fresh in their mind. This program is also being looked at by the breast screening program, as is the ABUS, but both of these will take longer to get through the more rigorous screening assessment than potentially we can apply them to symptomatic services. And as I say, that one, we're looking at developing a bid with Humber Coast and Vale Alliance, and we would be looking for a pilot site in the northeastern North Cumbria, potentially next year, if you know, if that bid comes to fruition and you know, the evidence stacks up in terms of support for that. The final one that I'm going to talk about is a company called Blue Prism, who provide robotics support to companies. So this is, if you like, an automation of admin tasks. And I've put a little baby robot on there. But essentially, it's not a robot that you would have running around in your clinics or in your admin offices. It is something that would sit inside your computer and automate admin tasks. So we already have an example in the Southwest of a cancer alliance that has supported these kind of innovations, and they already run their 2-week wait referrals through this robotic process. So essentially, when the referrals come in from primary care, they are automatically, if you like, uploaded onto the relevant hospital systems without the need for a person to do that in most cases. So where the referral is complete, and it has all of the necessary information, then that would be automatically populated. Obviously, any referrals that are missing information or have an incorrect entry in a box, those are the ones that are siphoned out and given to your human operators to make a decision about whether it needs to go back to primary care for further information, or whether it's just been a user error in a box, and they can make that adjustment, and then the task can be automated from that point on. I think we were talking about this a little while ago when we were looking at digitalising the cancer pathways work, when we were looking at the prostate pathway and thinking about how we could move to more digital interactions on that pathway rather than paper or electronic to electronic interactions. But I think especially now with COVID and the extra admin burden of adding in the COVID tests and the reassurance that's needed to patients about how safe it is to come into hospital, we could remove some of that admin burden by automating some of those admin tasks. We know that Blue Prism is already in use in our area, so in County Durham and Darlington and in Gateshead, they're already using Blue Prism, but not for cancer yet. So I think our job with Blue Prism would be about supporting cancer services in developing business cases to use robotics for some of the cancer processes, which we know are already happening around the country. So if you like, there's already the scripts written that would enable a very easy transfer of this technology into cancer services. So next slide, Sue. So this is my final slide. It's just a recap of what I've spoken about so far. So my job was to update you on the National Cancer Team initiatives around innovation, colon capsule and cytosponge, what we're planning to do locally, ABUS, digital PTL and Pinpoint, and some of the things that we are finding out more about. So before I hand over to my colleague Steve from the AHSN to take us into the unknown about innovation, have we got any questions about the technologies that I've spoken about before? So I'm just looking in the Q&A, and I see there's a question from Annie about good to see how colon capsule works. Do we have any impact evidence from pilots, and what's the timescale for implementation for patients? Okay, Annie, so we don't have any impact evidence from here because we're going to go live on the 1st of January. We do have some colleagues around the patch who have been trained in this technology. So at the point that the kit hits the hospitals, which should be pre-January, so we're expecting the deliveries to come out in the next couple of weeks, we should start to see these patients being booked in for the use of this technology from the 1st of January. Some of our hospitals will be awaiting a clinician to be trained, but I think the training starts from the 5th of January, and people do that in their own time. So, you know, it could be as short as a week to turn that around. It could take longer depending on how many patients they've got coming through that they can read and feedback on. In terms of evidence, a lot of the work that has supported the case being developed at the national team level was based on the ScotCap program. So that's a colon capsule endoscopy program that ran in Scotland, and you know that we've got good evidence of that. It's a slightly different cohort that they used to us because they really capitalised on the on using this technology for the remote patients. And really, at this point, we're going to focus on the patients that we already have in our backlog, and it will only be later, once we've cleared the backlog, that we'll look at providing this technology for those patients who can't necessarily get into clinic as easily. So that would be my answer to that one. If I haven't answered your question, Annie, please feel free to put another comment in the box. I'll move on to the next question, which is from Anne-Louise Grant around ABUS. So Anne-Louise says, with ABUS, although it sounds great in principle, given that the US scan reports are usually hot reported by whoever is scanning the patient, where is the workforce advantage? Will this only come with AI? So I think some of that, some of the US evidence does use hot reporting by the scanning, and you're right, there would be no workforce advantage in that. With the advent of AI, absolutely, you know, that could be used as a first reading of that image that is captured, but I don't think we need to wait for AI, because I think, you know, we could have this technology deployed in a clinic with a physician's assistant operating it, with the reporting done through the radiology networking project that's been up and running in the Alliance now for a little while, and some of the reading could be done remotely straight to a work list. So you know, I do think there's potential for us to see some workforce advantage even before the advent of AI. Right, the third question is from Sanjay, and this is a clinical question, so I may not be able to answer Sanjay because I'm not clinical. The question is, can the colon capsule endoscopy technology be used in patients with iron deficiency anemia to exclude upper GI cancers as well? So the honest answer is I don't know. It's a question that I will take to Katie Elliott, who is the clinical lead, who's leading on the introduction of this particular technology. So I think we'll have to say that we'll come back to you on that. But I would encourage you, you know, if you're interested in this particular technology, that perhaps you email Katie and ask the question, because I know iron deficiency anemia has been covered in those clinical meetings, but I wouldn't presume to try and give you a non-clinical answer to that. So next question is, can you give me some more details about who to contact re Blue Prism? Which trust is using it in the Southwest? Yes, Jay, I'll come back to you on that directly. I'll pick up your contact details from the invite list, and I'll get back to you about Blue Prism. So that covers the questions that are in the live Q&A. So what I'd like to do now is to hand you over to my colleague Steve from the Academic Health Science Network, who we are working with to develop our innovation offer going forward. Thanks, Steve.
Great, thank you very much, Sharon, and thank you for the invitation to come and talk to you and your colleagues here today about innovation. As Sharon says, I'm a business manager with the Academic Health Science Network that covers the North East and North Cumbria region. So what I'll do this morning is I'll just talk to you a little bit about what the Academic Health Science Network is and what our remit is as well, and then talk a little bit about how we go about identifying innovations and the support that we provide to innovators as well, and then talk and at the end talk a little bit about some of the work that we could potentially help you with in supporting identifying innovation in cancer. So you could have the next slide, please. Okay, so if you don't know, that the HSN is made up of 15 regional networks that cover the whole of England. We were established back in 2013 by NHS England, and our primary aim was really to help support the spread of innovation at pace and scale across the healthcare sector. Our initial license was for 5 years, so we were relicensed again back in 2018 for a further 5 years. And our commissioners at the moment include not only NHS England, but NHS Improvement and the Office for Life Sciences. And the commission through the Office for Life Sciences really supports the work that I do. So it's all around economic growth and supporting the health and wealth agenda. So as you can see, we have the 3 core objectives. Obviously, one is to help transform patient safety. So we have a number of regional and national programs that support patient safety initiatives. We also look to improve population health. So again, we have a number of regional and national programs that we're mandated to support around health improvement. And as I've just said, through the Office for Life Sciences Commission, we have a mandate to help generate economic growth for the UK PLC. So the next slide, please. So this is just a diagram that illustrates what we call our innovation pathway. And this innovation pathway really encompasses the whole journey of bringing innovation all the way from initial ideas all the way through to clinical trials, evidence generation, evaluation, commercialization, and finally ending with adoption and scale. In the North East and North Cumbria region, so what is central to the success of the innovation pathway are our commission delivery partners from the regional healthcare infrastructure who support the provision of a number of services all the way along this pathway. And our member organisations, which is all of our trusts and other organisations, they can access the expertise of the HSN and its delivery partners across this innovation pathway, depending on obviously where you are within this pathway. And through this pathway, this helps us to enable companies to access expertise across the NHS as well, and to help ensure that what companies are bringing to the NHS is actually required and useful to the delivery of services across the health and care sector. So can I have the next slide, please? So this is just a list of the support that we provide for innovators and the NHS, and as I said, the AHSN delivers these as our core functions. So we've ran a number of unmet needs challenges, and this has helped us and helped innovators to understand what and where the healthcare demands are, and what are the local evidence requirements needed to access the NHS market. We will also support effective signposting. So this is really the HSN acting as the first port of call for information, for building networks and contacts throughout the local and national innovation landscape, so that we can direct innovators to additional support or market access. We also offer practical support to commissioners and providers on uptake, as well as collaboration opportunities and dissemination of best practice. We also support real-world validation, study. So this is really looking to increase the capacity and capability to broker regional partnerships with commissioners and providers to offer these real-world testing opportunities. And some of the examples that Sharon had mentioned earlier could potentially fall into this category of support and help that the HSN can provide. We also help innovators with them articulating what their value proposition is around a particular innovation. And this is really more help with recognizing what the opportunity is that they're bringing to the NHS and whether that innovation matches a known need. You know, how widespread is the opportunity and its relative importance, as well as indicating what evidence may be required by future users and buyers of any particular product or service. And then finally, we help to support adoption and spread of these innovations. So this support is around like scaling up of innovations, which are shown a promise on a local level, but we do this in a coordinated manner and always with evidence-based information behind that as well. So I'm going to the next slide, please. So I was asked to sort of illustrate how we identify solutions and innovations that might be useful for the health and care sector and for the NHS. And in here I've just listed a small list of the core resources and methods that we use to identify these particular solutions. So Health Tech Connect. So this is basically a database of devices, diagnostics and digital health technologies that are intended for use in the NHS or wider UK health and care system. It's an online portal that's being funded by NHS England and it's operated by NICE. And its purpose is to act as a means of connecting innovators and their technologies to the right people from the right organisations at the right time to help get these technologies developed and assessed and used and adopted as quickly and efficiently as possible. And submissions to Health Tech Connect are reviewed by a number of varying organisations, including NHS Supply Chain, NICE, NIHR, and the HSNs. We are mandatory assessors of all submissions, so we basically see everything that comes in through Health Tech Connect. The next area is the Accelerated Access Collaborative. So this was obviously set up following the Accelerated Access review that was done a few years ago. And the main purpose behind this collaborative is to try and remove barriers and accelerate the introduction of groundbreaking new treatments and diagnostics which can transform care. And the AAC, as we call it, supports all types of innovations. So this can be medicines, diagnostics, devices, digital products, technologies that support pathway changes and new models of workforce delivery. And the HSN national network is one of the main primary delivery partners of the Accelerated Access Collaborative. So anything coming through that, the HSN would support the implementation and rollout of these across our various regions. And then we have the MedTech funding mandate. So this was introduced in the NHS long-term plan, and this is to support getting, again, effective and cost-saving innovative medical devices, diagnostics and digital products to patients faster. And this will be launched in April 2021. So this is something that we're getting ready to help support. And again, the HSN network will be the primary delivery partners for those products and services coming through the mandate. And then the HSN, we have our Innovation Exchange, and this is designed to help innovators understand what the NHS challenges are and help connect them to the help that they need. This is actually funded by the Office for Life Sciences, and it builds on the HSN's expertise and cross-sector connections, enabling us to identify common challenges and quickly bring people and organisations together to develop, test and spread proven innovation. And the HSN Innovation Exchange is actually part of the Accelerate Access Collaborative as well. The HSN network also runs a number of accelerator programs, and these are all run locally or across our regions, and these are really there to help support health innovations. Specific examples is that a number of the HSNs run a number of digital health accelerators, as well as research and innovation type accelerators as well. And then finally, we share knowledge across the national HSN network. So in collaboration with the other 14 HSNs, we help support the adoption of innovations on a cross-regional basis. This is all based on our knowledge of the local variation that is inevitable as the NHS has multiple delivery approaches, but we use that sort of local knowledge to help innovations that have been adopted and spread in other parts of the country to help them to spread that to other regions of the UK as well. So the next slide, please. So I just wanted to talk a little bit to you today about the Cancer Research UK report that came out recently back in, I think it was October. So this was really their roadmap for the early detection and diagnosis of cancer, and they made a number of recommendations across four themes. These themes were, as I say, understanding risk and prognosis, looking at biomedical data science and data systems, around incentivizing and supporting the development and commercialization of technologies, as well as health system innovation and how we accelerate adoption of these across the network. So the four themes within the report highlighted a number of policy recommendations to the UK government with the vision to ensure that in any future early detection and diagnosis of cancer is delivered as a routine in reality, and this vision would address hopefully the barriers to implementation and incentivize industry innovators and investors into the early detection and diagnostic space, and to help accelerate the evaluation and adoption of these technologies. And certainly the HSNs will be looking to sort of support the delivery of these through our networks. So the next slide, please. So this really leads me on to sort of the questions I wanted to discuss with you around what are the unmet needs facing cancer, and how can innovation address this? I do know, so obviously, as you know, one of the ambitious targets of the NHS long-term plan is to detect 75% of cancers at stage 1 and stage 2 by 2028. But obviously there are substantial barriers for this early detection research to achieving validation, such as obviously the complex and unclear biology that sits behind a number of these cancers, the limited availability of good quality samples for research and development, and as well as the lack of funding to sort of help translate these innovations into market-ready products and services. However, as I say, with the emerging technological capabilities and increased urgency that we've seen since the beginning of the pandemic, we believe that there's an unprecedented opportunity now to see how we can transform health outcomes in cancer. And the HSN would obviously like to support you to explore some of these possibilities, and obviously see what are the gaps in clinical practice, and how can we help you to identify solutions to help fill those, and to help really address the needs of the cancer community and help provide, as I say, better outcomes for patients. So I'm basically going to end it there, but I would really welcome your comments and suggestions of how we could sort of help support you in addressing these gaps within the cancer ecosystem, and how we could identify innovation to help address these various gaps and issues within delivery of cancer services. So with that, my next slide is just my contact details. I'll be very happy for people to contact me directly, or to contact Sharon and the Cancer Alliance if you wanted to have further discussions around how we can potentially help you with that. But very happy to take any questions, or if anybody's got any comments on any of that at this time now. So thanks very much.
Thanks, Steve, for that. Certainly helpful to understand a bit more about the AHSN and where it fits in the system, because, you know, I've been with the Cancer Alliance for a few years now, and that relationship and that bridging between research and industry was something that I didn't know about prior to that from my previous NHS work. So thanks for that. I did just want to offer the opportunity for colleagues to put any questions in the Q&A. We know that because of COVID, we have significant unmet needs that is sitting in a backlog. And some of those people who are waiting diagnosis or investigation at the moment will go on to have cancer. You know, they have been prioritised as lower risk. That's the reason that they're in the backlog and haven't already been treated. However, you know, even some of those lower risk patients will turn out to have cancer. So, you know, we know that where there are tools that can help us more accurately prioritise those patients, that they are really helpful. You know, we've got a recent example of implementing FIT into the colorectal pathway, which has given us a real tool to enable prioritisation in that pathway. And I think one of the key things that is an unmet need is a similar thing to FIT, as in that sort of prioritisation tool or filtration tool for some of the other cancer pathways that we have. And then there's the whole challenge of what about all of the unmet needs of the patients who are sitting at home with worries, concerns, or not even recognising that they might have signs or symptoms that point to cancer. So, you know, I think the potential there is huge, and we really welcome kind of working with you to address some of those unmet needs going forward. I have just dropped a couple of dates into the Q&A. These are for events that we've already got set up to kind of further progress our work on some of the innovations that we've talked about. So working with the West Yorkshire and Harrogate Alliance, we've got a demo of ABUS on the 17th of December at 10:30, but appreciating that is very short notice for colleagues. We'll also be setting up a further demo on ABUS in late January to allow a bit more notice time for that. So, you know, we really need colleagues to come along to those demos and help us investigate the benefit of these innovations to the system, but also challenge on the benefits. You know, so, you know, really welcomed Anne Louise's question about the benefit of ABUS, because, you know, it's your insights really from the coalface that will help us make decisions about these technologies. And then Jay, you'd wanted some more details about Blue Prism. So we have got a demo with them set up in January the 13th at 12:30. And, you know, would welcome interested colleagues at those events. Please get in touch if you would like to join us then. And, you know, if those dates don't suit, also let us know, and we can look to do anything, any other dates, you know, if particularly if, you know, out of hours is the only option as we're working our way through wave 2 and the pressures of flu and COVID vaccination coming along. I appreciate it is incredibly challenging to come out of practice at the moment. Steve, did you want to come back at all?
Yeah, I just saw there was a question in the chat from Manny, which was just asking about where the local knowledge that we get from. So I probably didn't make it absolutely clear, but so we cover the whole of the northeast North Cumbria region, and we have we have basically agreements in place with all of the trusts in our region. So we have good links in with the trust. We also have very good links in with all of the CCGs across our region, as well as the clinical speciality networks and groups as well through the CRN. So we do have a lot of very good contacts with the various groups and networks and individual clinicians right across the region, and as I said, and also as well with our commissioners as well. We're also obviously are working very closely with the ICS around their priorities as well for that, and obviously working building relationships with the ICPs as well in helping them to be able to deliver the health and care in the future once they are sort of like fully mandated and ready to go. So we do see ourselves as being sort of integrated into a lot of these various organisations and discussions that are going on a regional basis.
So I think, given the particular format that we're working to today, it's going to be a bit tricky to try and have any interaction or discussion about what people might see as their priorities for you know, areas of innovation. But I suppose what we wanted to do this morning was to talk about the offer, you know, which is, you know, we've got some capacity here by our work with the AHSN to be able to investigate and address needs that clinicians are identifying in the pathways that need innovation. So, you know, as well as capitalising on the known, the things that we know are in the pipeline and are coming along and can hopefully be, you know, positive improvements in our cancer pathways, we can do some thinking with the AHSN around the unknown, around these unmet needs, and take those unmet needs out to industry and say, here's our problem. We want to do earlier diagnosis. We want to do faster diagnosis. We want to improve treatments, whatever it is, which part of the pathway, and ask them specifically to come up with solutions for those issues. So that's the offer on the table, I guess, from this session. So please get in touch if you would like to, as I say, either support or challenge us in that process. We'd welcome both. With that, then, I think I will draw the session to a close. Thank you all for attending. As I say, dates in the diary if people are interested in attending the demos that we've got set up. We will take the questions that were asked that I was unable to address in the session, and we will get back to you on those. But for this morning, I'll happily give you a little bit of your valuable time back, as I know that we're all under significant pressure at the moment. So thank you very much for your input this morning, and goodbye.